And today we're going to be talking about partnerships that help reach populations that unfortunately all too often have really high levels of unmet need for care. And that's first responders and veterans and farmers.
For first responders in Missouri, they have the backing of a 24/7 crisis continuum to support them and serve as an alternative to strained systems.
We have an entourage of mobile crisis staff that go out 24/7, 365. We are able to de-escalate just simply over our 988 crisis call center. We are only engaging police less than 3% of the time.
In Kansas, they don't just care for veterans, they provide care that shows up wherever they are.
And the veterans, I think, as a population, when they are triggered, the triggers are very loud.
We do something called hot handoffs. And that's just really about meeting the people where they're at.
Again, for us caring for the people who have cared for us, and Kansas having a very large military presence, that was such a priority. We love the fact that we put it in our legislation. We love the fact that it's a priority of the CCBHC model. Being able to go to a VFW or an American Legion and having a veteran going in there and someone saying, I'm doing okay, but I think Joe's having a tough time.
And for farmers, going above and beyond to provide access and support in a way that is most convenient for them.
But we have farmers who will keep sometimes a telehealth appointment on the back of a tractor.
We'll go to feed stores, put up posters, have those kinds of conversations because those are the people they're talking to. And so if they can't buy their feed this week, hey, maybe that's a warning sign.
Learn how CCBHCs in Kansas and Missouri provide unparalleled care to special populations and the communities they serve on this episode of Wellbeing Wednesdays.
Hello, and welcome to Wellbeing Wednesday. Today we'll be talking about certified community behavioral health clinics, also known as CCBHCs. I'm Rebecca Farley-David. I'm a senior advisor at the National Council, and I work on all of our CCBHC efforts across the organization. As a refresher, CCBHCs are a new way of delivering and paying for care that allows clinics to focus resources on specific communities in need within the area they serve. And today we'll be joined by leaders from 2 states that have used the CCBHC model to transform access to care for first responders, veterans, and farmers. I'm honored to be joined today by Lauren Moyer and Kyle Kessler. Lauren and Kyle, welcome. Please start by introducing yourselves.
Yeah, happy to be here. Lauren Moyer with Compass Health Network. I'm an executive vice president there of our behavioral health services. Our agency is one of the first in the 8 demonstration states to become a certified community behavioral health clinic, or CCBHC. We serve about 46 counties throughout the state of Missouri, both rural, suburban, and urban landscapes. And we served a little over 140,000 individuals this past year.
Hi, thank you for having me. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers of Kansas. We represent all 26 licensed mental health centers around the state, and now all 26 are also certified community behavioral health clinics, certified community behavioral health clinics.
Congratulations. Statewide in both states, Kansas and Missouri. That's a huge accomplishment.
Feel great about it.
Yeah. So thank you so much for being with us. We've talked about CCBHCs before on Wellbeing Wednesdays. And one of the areas that I want to focus on today, because it's one of the areas where we've seen a lot of innovation in the CCBHC space, is community partnerships. And just as importantly as the innovations that we're seeing popping up is the fact that CCBHC provides a financing model to support those innovations, to support scaling them and replicating them. And today we're going to be talking about partnerships that help reach populations that unfortunately all too often have really high levels of unmet need for care. And that's first responders and veterans and farmers. So let's start by talking about first responders. And when I say first responders, I'm thinking police, sheriffs, firefighters, EMTs. We know that when someone is experiencing a mental health or substance use crisis, that when crisis services are not available, all too often it's those first responders who become the de facto crisis support for people with mental health and substance use needs. And so I'm wondering first, Lauren, can you talk to us about how, as a CCBHC, how has Compass expanded its crisis response capacities?
Yeah, so at Compass, and I think just in Missouri alone, we have really been able to build out our crisis continuum of care under the CCBHC model. Historically, And inadvertently, we created a lot of gaps in our system because our crisis services were so reliant on a new, initiative item or a grant that only lasted 3 years with not a sustainable piece in it. The CCBHC Prospective Payment System, or PPS, has really allowed us to build the crisis continuum of care into our cost, which has in turn provided invaluable support to our first responder community. We truly are able to create a safe place to, go. We have behavioral health crisis centers, 25 in 2025 throughout the Missouri landscape. And that's an alternative to the hospital. It's an alternative to jail. It's an alternative for that police having to respond unnecessarily out on a street. He or she can actually follow up with a more urgent need, an emergent need that is existing. We have an entourage of mobile crisis staff that go out 24/7, 365 to help a parent be able to keep their youth in the home instead of having to take them to the emergency room unnecessarily. And we always have someone that will answer the phone 24/7 to just be there to listen to folks. We are able to de-escalate just simply over our 988 crisis call center. 92% of the calls, we are only engaging police less than 3% of the time. But more importantly, I think it's educating our first responder system. And we've really been able to have critical liaison positions that go out and about. They respond with our police. They educate our, EMS. They're letting them know there is a different approach, and we're here to help be your partner and really take that behavioral health situation to a different level instead of having to go to the hospital or jail.
Amazing. I want to come back to those partnerships because I think that's one of the key aspects of what you do. But before we go there, Kyle, can you tell us more about how Kansas's CCBHCs have expanded crisis capacity?
Yeah, I think it's really the part of the secret sauce of the CCBHC model, right? And one of the things that we had really committed to and bought in on was, even as we were developing the policy piece, the strongest supporters outside of our system were law enforcement, the Kansas Sheriff's Association, the Kansas Association of Chiefs of Police, the Kansas Peace Officers Association, all testified in support of this legislation because they love the crisis, the mobile crisis response, and those kinds of things. So if they have someone who they know is suffering from a mental health crisis, one example, someone in the middle of the night up in a tree with scissors, they call the on-call person or the clinician or case manager and bring them out, de-escalate the situation, and it doesn't become a whole neighborhood or community event, right? Which it would have been several years ago. And plus, it helps us, especially in, I think, the rural and frontier counties in Kansas, be able to help those law enforcement agencies stretch a little further, because if you have someone in a mental health crisis, but you've only got 3 sheriff's deputies or a police officer on duty, you may end up taking almost all of them, off of their regular patrol. And so it really stretches the resources very thin.
And how did the CCBHC model itself help with these crisis capacity investments? Let's talk a little bit about the resources this model brings.
Yeah, so I talked a little bit about the prospective payment system. And so with a lot of the services in crisis, we really are trying to have a culture of, no wrong door. And so regardless of your pay source, regardless of what time of day, we offer free services for our crisis services, so everyone. But that is allowable because we're able to build that cost into our PPS rate. So then we offset that with our core services. And so I really think that our state really advocated and was able to support with some one-time startup funds to help us kind of build out the model, help cover costs of staffing, help with some renovations of the space that we needed. But from there, we can then add that to our cost ongoing. So it's really been a game changer. And I think it's an unprecedented time in our crisis system that we're now able to go fill the gaps that we created.
Yeah, I would echo what Lauren says in that regard. I think that it did help substantially to have the CCBHC grants. And obviously, lion's share of the credit goes to the National Council for You All's advocacy on those because it provided a long enough runway. And there have been a lot of points where it was pretty uncomfortable, but having the funding and being able to develop that infrastructure, whether it was clinical, medical, or the recruitment processes to get up and going, I think it has been vital. But the prospective payment system, even though we know from a study in Kansas that costs in the system are about 40% higher than what they were under fee-for-service, the access to care is 75% higher. That's a pretty good return on investment and something to be pretty excited about. So over time, we believe that costs might go down some and access to care goes up. And so we keep that return on investment going. And it's absolutely becomes one of the symbols of the system.
Yeah. Not to mention the cost saved from avoided hospitalizations, avoided emergency department visits,
Absolutely.
And even although this is not reflected in Medicaid budgets, costs saved by police departments, I think, who are no longer responding to crisis calls in the same way they used to.
And we say we say regularly that we're the part of healthcare that can save you money, in addition to keeping families together, in addition to allowing resources to be directed to the most acute cases.
Yeah.
Just to speak a little bit to that cost savings, we've taken a very conservative approach on how we calculate our cost savings with specifically our 7 behavioral health crisis centers. And in 1 year alone, not even shy of a whole year, I think it was like 9 months, we saved over $86 million in avoidance from those who would have otherwise gone to the emergency room.
Wow,
Amazing.
that's incredible.
Mm-hmm. And that's just 7 out of the 25.
And not to mention the emotional toll on people who would have gone to the hospital or emergency department and instead were able to access services and support in their community.
Yes.
Amazing.
The crisis center model is also itself an incredible investment. And so those to be sustained and supported by the CCBHC model just modernizes our systems that much more, right? I think we had one of our sheriffs referred to one of our crisis centers as a port of calm for people in mental health crisis, which really landed very, very well. I mean, with the policymakers and all the bipartisan support that we've seen from folks.
Yeah. Lauren, you mentioned earlier the partnerships that you have with law enforcement. Can you tell us a little bit more about what those partnerships look like?
Yes, we really have a very robust crisis intervention team model throughout the state of Missouri, or CIT. However, we've taken it just even steps further with the rollout of 988. And we really wanted to go more upstream. So we've heard from our officers. We go to all the roll calls, whether that's on the weekend, overnight, to really make sure that we're saturating all of our police officers and understanding like how to tap into mobile crisis. But more recently, we took it even upstream with the 911 dispatchers. And so we have now set up co-locations or call transfers from 988 for 911 behavioral health related calls, so that we don't even have to have an officer dispatched to the scene. We can just manage it over the phone or send mobile crisis. And those have been critical. And the biggest piece of cultivating those relationships is fostering the trust, understanding that action speaks louder than the words that we say. And so really going out on scene and showing like how we can do this together, and then how we're able to manage it effectively where they're not having to get involved, has really created just this synergy with our first responders. So even so much so with not just police, but our EMT partners, and, fire, and also really just trying to help with their own well-being. And so we offer a lot of support programs as well. I think when you're in high stress positions like our crisis staff and our first responders are, we have to really be vigilant in providing debrief support at any given time and any given moment, and then follow up for that. So we do offer debrief to our first responders whenever they need it, to the community, if someone has died from suicide, if there was a fire that unfortunately resulted in deaths, whatever the community needs, we try to be a part of that solution.
Yeah, I would add that even supporting those first responders becomes, I think, a higher priority with the CCBHC model and that partnership. And one of our centers just recently had brought in a speaker to work with the first responders in their county. And I know that the clinician, the therapist, and she's an author and talks about intergenerational trauma and things like that specifically, but she didn't know for sure what kind of reaction or interaction there would be. And she said, okay, we're going to start at the deep end of the pool. Is there anyone willing to volunteer what a traumatic event you've experienced? And we can work on that with you. And very quickly, it was coming on the scene of an accident where people had died or using a firearm in the line of duty. And so I think the recognition among law enforcement and fire and others now that there's so much of that trauma, I mean, just improves the quality of their lives and improves their capacity to care for the people that they're charged for caring for and helping. So
absolutely, because we all need support sometimes. And it's really wonderful to see how CCBHCs have been able to help the helpers and also help the people who are in crisis. So let's talk about another community in need, which unfortunately is our veterans and service members. And we've been reading news lately about the tragic rise in suicides among veterans, especially our younger veterans. Mm-hmm. And so let's start with Lauren. What has Compass put in place to help connect with veterans and service members and their families and reach them in moments of need?
Yeah, we've really tried to do a lot of different things, from more formalized things where we're a part of the Governor's Challenge for our service members, veterans, and their families. And that is where 8 states are a part of just a process of really making sure that we have a system of care that supports our veterans, from access to screening to identification to just resource building in general. To where we've actually done a lot more grassroots efforts as well. We have a lot of active military bases within our Compass Health Network service area, as well as National Guard, where we do something called hot handoffs or warm handoffs, depending upon the situation. And that's just really about like meeting the people where they're at. A lot of our veterans, want it to be a little bit more confidential. And so really kind of going to their home or meeting them where they're at, to kind of remove some of that unknown or that stigma. Because oftentimes it could mean they lose their security clearance in their position, depending upon whatever it is that they're going through. And so that's rough and tough. And we want to provide a very trusting environment for them to share their story. So we've not only partnered with those who might refer to us, but the actual members themselves will go to bars and put up signs. We'll go to, VFW centers, like things where people are at in our communities to know that we're here to help, and we're here to support. And get them the access that they need in the moment that they need it. I think that's also critical to, start where they are. So that might be coming in and offering debrief support, unfortunately, for a suicide death that they all may have just recently experienced, or an even more traumatic situation where perhaps some of their unit died. So we try to start where they are and kind of really be creative and figure out the best way to partner and what it is that they're needing. And I think that that's what's the richness of the CCBHC model, is that we really are focused on a really robust community needs assessment. And that means, what does this community need? And let's figure it out. We may not be the people to provide it, but let's all come to the table to figure out what that looks like.
Yeah.
Yeah. And the veterans, I think, as a population, when they are triggered, the triggers are very loud, right? I mean, so it could be something like the withdrawal from Afghanistan. I know veterans who felt just gutted by that. Mm-hmm. And so, I mean, for us caring for the people who have cared for us, in Kansas having a very large military presence with Fort Riley and Fort Leavenworth and McConnell Air Force Base in Wichita and National and Air National Guard installations. I think that for us, that was such a priority. We love the fact that we put it in our legislation. We love the fact that it's a priority of the CCBHC model. And so, as just again, once more, I'm sounding like a parrot with Lauren's comments, but being able to go to a VFW or an American Legion and having a veteran going in there and someone saying, I'm doing okay, but I think Joe's having a tough time. So maybe if you get a chance to just look him up and visit a little bit, don't even have to necessarily open a case file or some of those things, but just count the interaction and monitor the situation. And, prevention or intervention comes in a lot of different ways. Every interaction is an opportunity for an intervention.
Well, and what I appreciate about what you're sharing too is that some of what you're describing, these are not medical services billable to a payer. This is community outreach. This is relationship building. This is laying the foundation for people to get help at a later date when they might need it. And all of those things under a traditional financing model are not paid for. But under CCBHC, you can see how this is bringing that investment into those services. Yeah.
I would also just to mention that I think that's the cornerstone of CCBHC is we've really seen our engagement rate go up. And if you think about it, we want to trust the people that help us, and engagement and relationship building is at the foundation of that. And so I really feel that that's what the CCBHC has allowed us to have time to intentionally do.
So both of you come from states with very large rural sectors, big agricultural industry. Mm-hmm. How has being a CCBHC helped you and helped your members connect with farmers and ag workers and other people who may typically fall through the cracks and not be able to access help?
Do you want to go first?
I can. I think for us, again, something we're very excited about, and I think televideo has helped a lot of that as well, right? I mean, because it used to be that some of the communities, someone maybe didn't want their pickup truck out in front of the mental health center facility or something, or have people going, I wonder what they're in there for. But that has gone away more and more, and the stigma is going away. And even farmers or agricultural workers realizing, hey, my kid, this social media thing is an absolute hot mess. And so we need some help figuring some of this out because of the exclusion or isolation or bullying that can occur in those areas. But we have farmers who will keep sometimes a telehealth appointment on the back of a tractor. So, I mean, any kind of access, again, going back to access probably being my key word. If we were doing a word cloud, access and modernization would be my two. And so us bringing the information to those workers and recognizing that we are highly subsidized systems from county and state government, but that's also partly because the commercial and private insurance industries have, in my mind, totally slacked off in trying to reimburse fairly for the work that we do. If you're getting reimbursed $60 an hour, that doesn't pay for an hour of barely case management, let alone getting to clinical work.
Yeah, absolutely. I would say some other things that we've really worked on with our farming community, because we are seeing an uptick in suicide rates, specifically in that population. And at the foundation of it, when you really dig deep and start to talk to community members, we've had a lot of droughts that have impacted their business, right? We have a lot of folks that have access to guns because that's their livelihood. If they have a wild animal on their property killing their cows, they need that. But now they have access to a lethal piece that could take their lives. And unfortunately, we continue to see that. So we've partnered with banks if they know of people they're going to foreclose on. Like, hey, here's some information about us. We partner with the farming community to say, like, we can, provide support, try to access resources. So just having larger conversations around what to look for in your loved one, how to have safe means restriction, having those vulnerable conversations. It's not about, being too proud to share that. And so really kind of getting into the nuts and bolts of like you have a lot on your shoulders. Like, how can we help support this? And really helping their family understand, risks and warning signs and symptoms to look for. So having those hard, vulnerable conversations is really what our outreach folks have been trying to really get with. And so we'll go to feed stores, put up posters, have those kinds of conversations, because those are the people they're talking to. And so, like, if they can't buy their feed this week, hey, maybe that's a warning sign.
Yeah. Well, I wish we had all day to talk about the incredible work that you're doing in your communities. But as we close out, I just want to reflect that the CCBHC model, it's 8 years in to this model. We've seen a lot of momentum behind it, but it's not everywhere yet. And I think there are still a lot of people who don't know what a CCBHC is. And so I'm hoping you can tell us in maybe just one sentence, what would you want the public to know about the value of CCBHCs?
There's no one who believes I can do anything in one sentence. So I would say the key pieces of the CCBHC model go back to modernizing a system that had been neglected for generations, not just decades. And it also has to do with increasing access to high quality services and treatment. So those places that were the medical side, which was loss leader for almost every mental health center in Kansas, is no longer in that role. So we are recruiting more psychiatrists, more nurse practitioners, physicians associates, and so on and so forth. So modernization and expansion of access.
That was pretty close to one sentence. Nice.
It was a run-on.
I mean, all of those things. And from just the clinical perspective, like, I would just want the community to know CCBHCs really are focused on no wrong door, high quality care and access when you need it the most.
It's a beautiful summary. Thank you both so much for being with us. I really appreciate your time and your comments.
Thanks for having us.
Thanks.